Hello everybody. It's a great pleasure to join you in the review course of the Egyptian Society of Cardiology. My topic today is regarding chronic coronary syndrome and optimal medical therapy. As you all know, ischemia is a balance between demand and supply. When you mention demand, you have to remember heart rate, wall tension, and myocardial contractility. What about supply? Supply of the heart with oxygen means coronary vascular resistance. If you have coronary stenosis, you will have reduced supply. Aortic left ventricular diastolic pressure gradient, coronary arteriovenous extraction, and of course, diastolic filling period. Any one of these can control the supply of your heart with blood and oxygen. If you have a normal heart and increase the demand, there will be vasodilatation and increase in the coronary blood flow. But if your heart is abnormal, you will have vasoconstriction and reduced coronary blood flow. Myocardial ischemia is a balance between demand and supply. The chest pain is only the tip of the iceberg regarding myocardial ischemia. Before that, your patient definitely may have ST-TOF changes in the ECG, systolic dysfunction by echo or myocardial imaging, nuclear imaging, diastolic dysfunction by echo or nuclear, metabolic changes by positive emission tomography, paired perfusion by PET or SPECT studies. And all of this may take place without the apparent of chest pain. Chest pain is the tip of the iceberg. What is my goal in treatment patients with chronic coronary syndrome, known in the past as chronic stable angina? My aim is to relieve symptoms and to improve survival. Medications may improve symptoms, such as nitrates, beta blockers, and calcium channel blockers. However, to improve survival, you have to concentrate on lifestyle modification, antiplatelet, statins, and maybe ACE inhibitors. This is the 2013 European guidelines. As I have mentioned, if you are aiming to improve survival and prevent events, you have to concentrate on lifestyle management, control of risk factors, education of your patient, and aspirin, statins are important. If you are aiming to relieve the symptoms of your patient, you have to remember first line and second line medications. By first line, we mean short-acting nitrates, sublingual nitrates, to immediately remove the chest pain, and beta blockers or calcium channel blockers or combination of both. Second line, including long-acting nitrates, ivabradine, working on the IF channel, funny channels, long-acting nitrates, nicorandil, ranulazine, and trimetazidine. These are the second-line medications in the treatment of angina pectoris, aiming to relieve the symptoms. Of course, you can transfer your patient for coronary angioplasty, and or CABG whenever there is an indication for that. Then we have the 2019 European guidelines for the diagnosis and management of chronic coronary syndrome. This is a new terminology for what is known in the past as chronic stable angina. Always remember chronic coronary syndrome. And the guidelines was clear. The change emphasized the fact that clinical presentation of coronary artery disease can be categorized as either acute coronary syndrome or chronic coronary syndrome. Why? Because coronary artery disease was considered by the guidelines as a dynamic process. Clinical scenarios of chronic coronary syndromes, according to the European Guidelines 2019, include the following: patients with suspected coronary artery disease and stable angina, symptoms and/or dyspnea. Maybe patients with new onset of heart failure or left ventricular dysfunction and suspected coronary artery disease. Third scenario, asymptomatic or symptomatic patient with stabilized symptoms less than 1 year after acute coronary syndrome, or patients with recent revascularization, less than 1 year. Fourth scenario, asymptomatic or symptomatic patients after 1 year after initial diagnosis of revascularization. Another scenario, patients with angina and suspected vasospastic or microvascular disease section. Or finally, asymptomatic subjects in whom coronary artery disease is detected at routine screening. All of these are included under the new terminology chronic coronary syndrome. This is to show you, my dear colleagues, that the natural history of chronic coronary syndrome is a dynamic process. Maybe very aggressive. Look to the red curve where your patient's death and myocardial infarction incidence is high. And compare this with the same patient after revascularization when he has a quiescent form, and in between patients with a low risk acute coronary syndrome and chronic coronary syndrome when they stabilize on medical treatment. Back to the pharmacotherapy of our patients, they include anti-anginal medications, antithrombotic medications, lipid-lowering medication, and other special groups medication. This is the guidelines medications of European Society of Cardiology 2019. You can appreciate the first row, the standard therapy. First step is beta blocker or calcium channel blocker. Patient is controlled, well and good. Not controlled, you have to move to the second step where there will be a combination of both beta blocker and the calcium channel blocker dihydropyridine. Not controlled, move to the third step when you may use second line medication. Example, long-acting nitrate, trimetazidine, ivabradine, and so from the second line medication, you can pick one according to your patient. If my patient has tachycardia, it's preferred, of course, to start with beta blocker or non-dihydropyridine calcium channel blocker. If my patient has bradycardia, please start with dihydropyridine calcium channel blocker. Patient has left ventricular dysfunction, heart failure, beta blockers will be preferred. Patient has low blood pressure, of course, low dose of beta blockers or low dose of non-dihydropyridine calcium channel blocker. So this is the frame of the guideline medication in selection of anti-anginal treatment according to the European guidelines. Let's go through to some of the European guidelines recommendations. Class 1 level of evidence 3C that medical treatment of symptomatic patients require one or more medications for ischemia relief in association with medications for event prevention. You should select your protocol of treatment by combination of one or more of the medications that improve survival, plus one or more of the medications that improve ischemia and relieve the chest pain. Of course, risk factors is a mainstay in the treatment strategy, and you should monitor your patient response every 2 to 4 weeks. For the purpose of angina relief, guidelines advise to give short-acting nitrates, class 1 level of evidence B, and as the previous guidelines, beta blockers and or calcium channel blockers to control heart rate is first line of treatment. Long-acting nitrates is 2,8, may be considered as a second-line treatment option if there is no control of symptoms of your patients. Nicorandil, ranolazine, ivabradine, trimetazidine, all should be considered as a second-line treatment to reduce angina frequency, class 2A, level of evidence B. Of course, nitrates are not recommended in patients with HOCM and co-administration of phosphodiesterase inhibitors such as sildenafil. Antithrombotic medications, important. Aspirin, 75 to 100 milligram daily, is recommended in patients with a previous myocardial infarction or revascularization, class 1 level of evidence A. Clopidogrel is recommended as an alternative to aspirin in patients with aspirin intolerance. Adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with high risk of ischemic events and without high bleeding risk, class 2A level of evidence A. This is important regarding some of the treatment options for dual antithrombotic therapy. Clopidogrel may be added in post-myocardial infarction patients who have tolerated dual antiplatelet therapy for 1 year. Rivaroxaban, 2.5 milligram twice daily in post-myocardial infarction patients more than 1 year, or multivessel disease, coronary artery disease, when the GFR is between 15 and 30. And of course, prasugrel, ticagrelor may be added as well. This is a recommendation for post-PCI patients with chronic coronary syndrome in sinus rhythm. Of course, aspirin is at top together with clopidogrel for 1 year. Clopidogrel, prasugrel. Let's jump to patients with atrial fibrillation. In this case, NOAC are preferred in preference to vitamin K antagonists. Proton pump inhibitors is recommended in patients receiving aspirin monotherapy, oral anticoagulant monotherapy, or dual antiplatelet and at high risk of gastrointestinal bleeding, class 1 level of evidence A. Of course, lipid-lowering drugs are important in improving survival in patients with stable coronary artery disease. Other drugs that may be given according to the situation, ACE inhibitors if your patient has other condition, example heart failure, hypertension, or diabetes. ACE inhibitors should be considered in chronic coronary syndrome patients at very high risk of cardiovascular events. This is 2A level of evidence. Of course, beta blockers, LV dysfunction, and in patients with previous STEMI, long-term oral treatment with beta blockers should be considered 2A level of evidence B. Patients of heart failure and reduced left ventricular function, you should consider, of course, ACE or ARBs, beta blockers, and diuretics if needed. Mineraloreceptor antagonist, the same thing. Ivabradine if your patient is in sinus rhythm, low ejection fraction, and heart rate over 70 beats per minute. Specific situations, diabetic patients, for example, the guideline stressed on the sodium glucose transport 2 inhibitors. They are class 1 level of evidence A in case of patients with diabetes mellitus and stable angina. Thank you.